fever, also known as San Joaquin fever, desert rheumatism, officially referred to as Coccidioidomycosis, and review some of the IDSA guidelines for the treatment of them. I realize that not everybody is an ID physician, but this is a disease is actually important in this area of Southern California in particular. We are fairly close to some of the endemic areas. As I mentioned, I'd like to review some of the basic disease concepts, the IDSA guidelines, which are the Infectious Disease Society of America, and understand the literature that these guidelines are actually based on. So I thought that as I was talking with Susan, we'd try to incorporate more audience participation to get everybody acclimated again to what coccidioidomycosis is. I've listed a number of choices: a dimorphic fungus, gram-negative rod, gram-positive coccus, or non-tuberculous mycobacteria. We don't have the audience participation, but make your selections and I'll let you know. Okay, we have a very intelligent and knowledgeable audience. It is in fact a dimorphic fungus. It has two phases, which are interesting. There's a saprophytic phase and a parasitic phase. Saprophytic phase basically is a phase where the nutrients for this organism, this fungal organism, are derived from the environment, dead material. The parasitic phase is when there are spherules that are encompassed into the tissue and can spread throughout the body, and they survive basically on tissues. The other dimorphic fungi that you may be or may not be aware of are actually Coccidioidomycosis, histoplasmosis capsulatum, and blastomyces. Now, what it means to be dimorphic is that you have two different forms. There's one form in culture, and there's one form in tissue, as I mentioned. In culture, if you were to look at these organisms, the fungal organism is a myceliae. If you look at it in tissue, it's a parasitic form, and that's at 37 degrees. If you were to incubate it at 37 degrees, you'd see the same form, a spherule. I'll show you more pictures of what it looks like. But as another interesting aside, these organisms were initially considered to be protozoa. They were considered to be parasites, and that's why it's referred to as coccidia. Coccidia actually is a term that refers to protozoans, and as I'll discuss in the history, all three of the major endemic mycoses or systemic mycoses in North America, the dimorphic ones, were actually originally thought to be protozoa, and I'm referring to histoplasmosis capsulatum as well as blastomyces. So the history is quite interesting. In 1892, there was a soldier, an unfortunate soldier in Argentina, who reported to the services of a surgeon by the name of Alejandro Posadas. He was a medical student at the time, but he was actually able to look at this patient with fungating lesions that were once on his face, spread into his arms, legs, genitals, and take tissue and actually look at it underneath the microscope. He thought, in fact, that it was a parasite as well. Unfortunately, the patient underwent numerous treatments at the time, none of which included commonly referred to common effective treatments that we have today, like the polyenes or azoles, and the patient died after 7 years of fever and increasing lesions. Now, I went down to Argentina last year and actually was able to see some of the original specimens from that patient. His name was Escura, or Domingo Escura, and they actually have a very interesting museum with a professor who is quite knowledgeable about the topic and a curator of a medicine history museum in general. Now, as I mentioned, after the initial paper written by Posadas around 1892, a year later, Rixford and Gilchrist, then at Cooper College, which later became Stanford College, determined that two immigrants also had a very similar presentation. This is not the picture, but something I think that would be similar, of these ulcerative fungating lesions throughout their body. And they were able to take specimens of this and look at it under the microscope as well. And they also thought this was coccidia. They referred to it as protozoan, and they named it immitis, meaning severe or not mild. Later on, there was another physician by the name of Oflis and Moffitt, two physicians who actually were able to take tissue from guinea pigs that they had infected with the fungus. They took tissue from a patient or pus from a patient, injected it into a guinea pig, and then looked at it under the microscope, and what they found were spherules. They took the spherules in turn and put them in a culture medium, and they grew a fungus. It appeared to be mycelia. They actually discarded it initially as a contaminant. But later on, they were noticing that when they infected some of the guinea pigs, that they would have some of the same fungating lesions as these patients. And so it was determined by looking at what these lesions looked like in the patients under the microscope and the guinea pigs under the microscope and injecting the guinea pigs with mycelia and then finding spherules, you would actually find out this is a dimorphic fungus with 2 different phases. I'll show you some more pictures of this that will help as far as understanding the actual process. But that's the history of how this came to be. In the 1930s, there was a physician by the name of Smith who studied San Joaquin Valley fever here in this area. And he was the first one to make the connection between desert rheumatism, valley fever, and coccidioidomycosis. His paper of a 17-month study in the 1930s was really the premier understanding, or the beginning of the understanding of how these diseases were in fact all the same, dimorphic fungus infection. Today, we actually have been able to determine phylogenetically that there are in fact 2 different species. What was once considered to all be Coccidioides immitis is actually now Coccidioides immitis within California, and outside of California, Posidacea, referring back to Posadas. So how do you get coccidioidomycosis? Well, basically, it's inhaled. You inhale the arthroconidia, and that goes to your terminal bronchiole and spreads throughout the lung parenchyma, enters lymphatics, and eventually can spread to other parts of the tissue throughout the body. It's thought that the macrophages engulf endospores, and those actually spread throughout to the lymphatic system, a very similar process to TB and histoplasmosis. In fact, the exact details are not completely understood, but this is what it's thought to be. Now, the areas of endemicity are the lower Sonoran life zones, Southern California, Central California, Southern New Mexico, and West Texas, and you do need to be aware of the fact that there could be reactivation outside the areas of endemicity. There are epidemics periodically, the most recent in 1990 to 94 in the San Joaquin area. In Bakersfield, there was approximately 1,700 new cases in 1992 alone. And it's thought to be that a previous heavy rain in the winter of, or the spring of 1991 was the actual cause of this. So I wanted to reiterate how the actual process of replication occurs. And what you can see here is the endospore that you might find in the saprophytic phase. It turns into mycelia, which extend apically and then septate. The septations break off and form arthroconidia. Now, the arthroconidia may just return back to the soil in the endemic regions, or in fact, they may actually enter, if somebody's inhaled, into the body, enlarged, form a spherule. The spherule itself will form endospores within it, and they'll burst and spread throughout the body, and the process repeats itself. The reason this disease is particularly important, and we see it on a more regular basis in certain areas of the United States, is the fact that we've had increasing population encroachment on areas of the southwestern United States. As we well know, Southern California has a larger and larger population each year, but areas like Fresno, Bakersfield, Arizona have gone from populations of 300,000 to 3.7 million projected in 2010. You can see the areas that the disease is commonly present by skin test analysis, basically looking for dermal hypersensitivity, is prevalent in Bakersfield, San Joaquin Valley, and in particular southern Arizona and parts of Texas. We don't actually do skin testing any longer because it's not actually commercially available. It's epidemiological studies, usefulness only. Most of the time we diagnose the disease serologically today. Now, getting back to some of the epidemiology, there's approximately 150,000 infections throughout the year, or each year rather, in California, or I'm sorry, in the United States only. This is not a disease you would see outside of North America. Most of these, this is where it's interesting, are actually subclinical, in fact up to 2/3. And the common presentation you may encounter with is acute or subacute pneumonia. Now some of these, approximately 5 to 10%, will go on to form pulmonary nodules or peripheral thin-walled cavities. Now, the great majority of people will overcome the infection, even if they do go on to form pulmonary cavities or have nodules. But there is a percentage, approximately 1%, who will go on to chronic forms of infection, chronic pulmonary or extrapulmonary infection. And there are certain risk groups or certain groups that are at risk. And those turn out to be African Americans, Filipinos, Asians, and people of Native American ancestry. Now, 30 to 50% of those infections in general also will go into people who are immunosuppressed, AIDS patients, lymphoma, solid organ transplant, rheumatological therapies such as TNF-alpha inhibitors. Now, how do we make the diagnosis? Briefly, just to review, it should be suspected in endemic areas. And there are great serological tests that we have today, which we did not used to have. They used to rely on 2-precipitin, which is basically an IgM test rather. But now we actually have ELISA as well as immunodiffusion. These are IgG and IgM tests. You may be familiar with the complement fixation test. I can take some questions on those at the end, but I'd like to move on to some of the main principles of what we need to be aware of. If you look through the guidelines, basically there's 3 main points you need to think about as far as management. Obviously, you need to be able to recognize the infection, you need to define the extent of infection, and you also need to look at the host factors and disease severity. By the way, is everybody able to hear me? I don't want to be screaming into this. Okay. Syndrome management is really the basics of how we encounter and how we deal with each particular syndrome. And the problem with coccidioidomycosis is that we do not have a lot of randomized, double-blind, controlled trials. A lot of this is observational. In fact, a lot of the initial treatment was actually experimental because we did not have much until amphotericin. So acute pulmonary infections are the most common presentation, chronic pulmonary cocci in that 1%, as well as forms of disseminated disease such as cutaneous and bone disease. In the worst scenario is coccidioidomycosis meningitis. Now, what are the agents we have to treat it? Well, we have amphotericin B. Now we have the lipid formulations, amphotericin, ketoconazole, fluconazole, itraconazole. Now, quick review of how some of these antifungals work. There is amphotericin, which basically has a mechanism of action of blocking or actually binding to ergosterol and causing a break in the cell membrane and causing cell lysis, whereas the azoles, the therapies I'll discuss, are actually an inhibitor of C-alpha 14-demethylase and actually prevent ergosterol formation, and therefore the cell membrane cannot form completely and results in cell death. Now, some of the newer agents I put over here to the side include beta-1,3 glucan synthase inhibitors referred to as echinocandins, which are actually experimental at this point. Some people may be concerned that there would be an actual antagonism between amphotericin B because it actually relies on ergosterol binding, and azoles because they would actually prevent ergosterol formation. That turns out not to be a major issue. Amphotericin B is actually a polyene drug with multiple carbon bonds, and it really came to the forefront in the 1950s. We were able to look at case presentations from the 1950s era of a disease that had no previous treatment, and then some incredible reports of people starting to get oral amphotericin. Here's a patient who actually had coccidial granuloma of the face. This is one of the original reports of use of amphotericin, who took it orally and actually got better. These are some of the treatments we used before we had amphotericin, and they're pretty brutal. In fact, the patients I mentioned in the history section initially, those 2 patients studied by Rixford and Gilchrist, as well as Posadas' patient, actually received some of these treatments. They're actually devastating in their own right. Things such as methyl violet, tincture of iodine. We have all used oil of turpentine on our patients, potassium iodine. These are all very brutal treatments. You can imagine up into the 1950s, this is what people would try to treat people with. So the real era of progress in treatment of coccidioidomycosis, when we didn't have to rely on amphotericin and all the side effects, as you're probably well aware of, the shake and bake syndrome, fever, hypotension, the renal toxicity issues, as well as having to give people IV drugs and later on intrathecal therapy. Those could be alleviated as we started to develop the drugs called the azoles. The azoles were systemically studied, started in the 1970s, and really came to the forefront with ketoconazole in 1979. Miconazole had been around but was fairly toxic. But ketoconazole was studied originally in the early 80s, and there's a study that came out by Stevens when he looked at 46 patients around 1983, and these are patients who had actually failed amphotericin and had tried ketoconazole as an experimental therapy. So you see here, the results may not be as impressive as you would expect, but these are patients who have failed previous therapies. 25% of those who had skeletal lesions got ketoconazole, had complete resolution. 12% of the chronic pulmonary, about actually 2 patients, and cutaneous, about 15 patients, actually had complete resolution. There's also significant improvement in the skeletal and chronic pulmonary lesions of patients who received ketoconazole. Now, a few patients worsened, unfortunately, but not nearly the percentage you would have expected. These are fairly impressive. Patients who had failed previous therapies now are actually down to 2 and 2 in the skeletal and cutaneous categories. Unfortunately, they don't report it directly in the article, but once these patients came off ketoconazole, they actually relapsed. The other issue with ketoconazole is the fact that it's actually toxic in its own right. It's a fair amount of nausea and vomiting, and there's inhibition of testosterone synthesis. So gynecomastia is one of the issues you'd come across. Now, the newer drug that came out after that was called itraconazole, and this actually alleviated some of the problems of ketoconazole. It wasn't nearly as toxic, and it was actually something that could be used orally and was considered to be able to achieve higher serum concentrations. Now, the original study that really brought this to the forefront came out in 1990, and this was an evaluation of 47 patients, and 46 turned out to be evaluable. 44 actually completed treatment, rather. And 57%, these again are patients who had failed amphotericin ketoconazole, now were able to be cured with itraconazole. So these were the new agents called the triazoles. They were one of the more advanced azoles that was able to be effective because it actually was more specific for the fungal enzymes rather than the actual mammalian ones, so less toxicity. But there was still toxicity, and the problem with itraconazole is that it has to be taken in an acidic environment. People are taking proton pump inhibitors, H2 blockers, for instance, may not actually be able to achieve serum levels that are effective. Fluconazole is really the therapy that you're probably most familiar with for a lot of fungal infections. In coccidioidomycosis, it's come to be the forefront, or one of the leading drugs to treat this disease. And that really came out in 1995 when Catanzaro and Galgiani et al. Looked at a series of approximately 22 patients who had disseminated bone disease, 14 patients rather, and they noticed that 12 out of 14, 6 responded to 200 milligrams, 6 responded to 400 milligrams. And so it was an approximate 86% response. So they took patients, got 200 milligrams. If you failed that, you went to 400 milligrams. I realize that this is not as interesting, but this is actually the basis of what we treat these patients on. So I realized that chronic pulmonary also had 11 of 22 who actually failed initially and then went on to response with 400 milligrams. So approximately you have 22 out of 40 patients who originally failed other therapies were now improving. Yes. Well, the problem is these patients were actually treated for upwards of 12 to 39 months. So the treatment was not stopped at the end of a lot of these therapies. This one, most of these patients were treated for approximately 39 months. Yeah, it's a problem because they look at this disease and a lot of these patients relapse. Now, it turns out that people have less of a chance of relapse with fluconazole than itraconazole. But of course, now the issue was, well, if we have a patient with coccidioidomycosis, whether it be cutaneous lesions that turn out to be histopathologically consistent with coccidioidomycosis, a spheral, or if it turns out that they have skeletal lesions or chronic pulmonary disease, should we use itraconazole or fluconazole? They actually tried to address this in 2000, and Galgiani looked at it, and the outcome basically noted that itraconazole and fluconazole were fairly similar at 8 months, which is what they were originally trying to study. And the 63% response overall for all comers, itraconazole at 8 months compared to 50% with fluconazole was not actually statistically significant. But at 12 months, which they did not initially intend to study, there was a significant difference statistically in favor of itraconazole, interestingly enough. Itraconazole seemed to have a higher overall patient response, and patient response was measured by looking at a symptom index score, as well as having to have some type of response at least at 4 months, and then a 51% or greater response at 8 months. So these are the actual numbers pointing that out. The other interesting thing to note is that fluconazole here looked at around 57% of all patients at 12 months, itraconazole 72%, but for skeletal lesions, 37% of those in the fluconazole group and 70% in the itraconazole group. So there's quite a bit of difference in the itraconazole group for skeletal lesions. So the other agents you may have heard of, voriconazole, caspofungin, posaconazole, those are all case reports. We don't have a lot of randomized controlled data, controlled studies in general, and we definitely don't have any here. But these are salvage therapies you can consider. Now, what's lymphit amphotericin B? Well, it's been studied in the murine model, but we don't actually have any human studies. But the nice thing about the lipid amphotericin is that you have much less renal toxicity. You don't avoid the other toxicities, but it's basically a bilamellar membrane of lipid with amphotericin crystals in between. So here's a case presentation that you should be able to look at now with all that knowledge of the studies. A 26-year-old female with non-productive cough, arthralgias, and tender spots on her legs. Her symptoms began on a recent trip to Phoenix, Arizona. She appeared non-toxic, afebrile, vital signs were stable, lungs were clear, her abdomen was benign, and she had this lesion on her right ankle, bilaterally actually, on the other leg as well, and her labs and chemistries were normal. So the question is, what's the next best step for a patient like this? Should you check the cocci serologies and CF and only treat if the syndrome worsens? Or should you assume this is coccidioidomycosis and start IV amphotericin? Should you start azole therapy, or should you call an infectious disease doctor? So A, all right, that's right. Although you could do D if you wanted to call me. The primary respiratory infection is an area of actual controversy. Some authorities would mention that you should treat these patients because you can avoid some of the dissemination, but the other thought process is that everybody disseminates and you just control it. It turns out that the recommendation for the most part, although it's not based on studies, is not to treat these patients. Most patients will overcome coccidioidomycosis with minimal treatment. In fact, just symptomatic treatment. You don't need antifungals. Now, the caveat to that is you probably would want to consider treating patients who have risk factors such as I mentioned before, immunosuppression, AIDS, lymphoma, TNF-alpha inhibitors, pregnant women, immunosuppressive state, horrible disease, coccidioidomycosis in pregnant women. Those patients actually need to be treated with amphotericin. In addition, people of Latino, African American, or Asian ancestry in particular, as I mentioned, Filipinos. So as I mentioned, the primary infection usually 1 to 3 weeks. It's very difficult to diagnose this. It turns out that it's very similar to a URI. You have to have a high rate of suspicion. It's something you should consider if you find out that patients are not responding to antibiotics. Uncomplicated versus diffuse is the basic differentiation. This is what a sphereal looks like in tissue. This is how you might inhale it. And again, the process, as I mentioned. The management is controversial. There's no data supported, but the immunosuppressive factors are considered. The other people you would want to consider treating, probably up front with fluconazole, a young woman like this, if she told you that she had weight loss, greater than 10%, night sweats, infiltrates, and a high COXY-CF. A COXY-CF greater than 1 to 16 is considered to be a sign of dissemination. And basically what that is a complement fixation test. They look at the amount of complement absorbed by the fact that you have antigens of coccidioidomycosis in your body. They present your serum to, they take your serum and they see at what point the addition of RBCs would cause lysis. If you don't have lysis, it's considered that your complement is used up. Once your complement once your serum is diluted enough, then it turns out that you do have lysis of RBCs. That's your titer. So any titer greater than 1 to 16 is considered to be high. It can go up to 1 to 64. Inability to work or symptoms greater than 2 months and higher age would be a consideration. As I mentioned, oral azole therapy would be a consideration here. Up front, probably for 3 to 6 months. Somebody had asked me earlier today, how long do you treat these patients? Probably around 3 months. I would check their serologies as well as their complement fixation serially, and I would look at periodic chest x-rays and clinically analyze them to consider stopping at that point. You probably follow them up for about a year, look for signs of other disseminated infection if they've had cutaneous or skeletal lesions, obviously, or persistent cough. Now, here's another case. Here's a man in his 50s who's been infected with HIV for 20 years. 10 days before presentation, he was admitted to another hospital with a productive cough and fever. He was diagnosed with community-acquired pneumonia and treated with ceftriaxone and azithromycin. He's got a past medical history of HIV, as I mentioned. He's on a low CD4 count of 35 and a high RNA level, which indicates he's probably not adherent with his heart therapy, especially in this day and age. He has a history of PCP. He lives in the southwestern United States. He's mildly cachectic. He's not in distress, but he does have a low-grade temperature, and he appears to be tachypnic. There was non-tender adenopathy in the cervical, axillary, and inguinal regions, and no thrush was seen. It turns out that he's got some hepatosplenomegaly. He has no hepatosplenomegaly and no skin lesions, and he's got 7,000 white blood cells and 1% eosinophils. Now, this is probably a different scenario. This is actually diffuse reticular nodular infiltrates you'd see with somebody with Coccidioides immitis, probably now referred to as postidacea, in a patient with HIV. And you don't want to treat these patients with observation. These are probably people you'd consider upfront aggressive azole therapy. If they're severely hypoxic, most people would go to IV amphotericin right up front. These are recommendations based on expert opinion for the most part. As I mentioned, we don't have a lot of studies, randomized controlled, especially in people of HIV. Now, what do you do if somebody comes in and they've got a pulmonary cavity, you've had a bronch, turns out they actually have Coccidioides species, but it was something noticed on x-ray and it's asymptomatic? Well, if it's asymptomatic, it's most of the time benign. It'll resolve on its own. It's frequently colonized with Coccidioides species, but there's not real need or urgent issue in treating these patients. You may consider, again, if the cavity is still detectable after 2 years or develops progressive enlargement or is immediately adjacent to the pleura. Now, complications you need to be aware of: there's local discomfort, there could be superinfection, hemoptysis. Most times you can treat these patients with those complications with oral azoles, and you should see improvement in 8 to 12 weeks. Recurrence, as I mentioned, is a major issue. It usually recurs after you stop therapy, although there is a cure rate in some of these patients. Now, what if you have a cavity that turns out to rupture? This turns out to be fairly dangerous. These patients require surgical treatment in most, if not all, instances. Rupture leading to pneumothorax. If they look at the study by Cunningham in 1982, they took 23 patients who actually had a ruptured pneumothorax from Coccidioidomycosis. And it turned out that almost all of them required surgical treatment. I think about 13 actually had to have a chest tube drainage, and another higher percentage, actually, I think around 3 to 4 patients actually required lobectomy. So the only caveat to that would be if you have somebody who's come in and actually had this for greater than a week, you may consider antifungal therapy prior to a surgical intervention. Now here's another case that you may come across. Somebody's getting antibiotics and it's not getting better. A woman in her 50s developed a painful left neck swelling associated with arthralgias, myalgias, fevers and chills, tenderness and swelling of the left shin, occurred episodically, and it's less severe in the morning but worse later in the day, and the lesion is increasing in size, becoming more indurated, beefy, heaped up, and later in the course more friable. Pathological fine needle biopsy reveals what looks like a spherial. What do we do now? It turns out the patient's serum CoxyCF titer is 1 to 16. IV ampho was started. The LP was done because of what I mentioned, the dissemination concern with that high CF was negative. What's the next best step? Well, you could start her on intrathecal amphotericin, continue IV ampho, or start azole therapy. Or you could just wish her good luck. So I don't see any enthusiastic answers. B. Okay. Continue IV info. Probably not unreasonable. Somebody like this, though, with not any evidence of further dissemination, is borderline. You could try to treat them with azoles, I would say. If she did not get better, you may consider going back to the IV info. I like using the azoles because they're oral, easier to take. You can take for a prolonged period of time, and you don't have to have a patient come to the outpatient IV infusion center and receive amphotericin. So this brings me to the next topic: disseminated infection, extrapulmonary, non-meningeal versus meningitis. So here's some disseminated lesions you may see. The IDSA guidelines basically recommend treating these people with itraconazole or fluconazole based on the previous studies I mentioned. The only problem I think here is that 400 milligrams, which has been systemically studied, is really a low dose of fluconazole. Most of the experts today, if you look at Royce Johnson, Kern County, they would recommend going up to 800 milligrams, even 1,000 milligrams. Most people don't have problems with toxicity, although some people still do have nausea and vomiting. Amphotericin B could be used if the lesions were worsening or in critical locations. Critical locations meaning vertebral column, cervical lesions. And there's always the consideration in these patients of surgical debridement and stabilization as an adjunctive measure. Most of the studies and the recommendations are based on observational or expert opinion. Now here's a case that I actually saw at Allevue. And the cases I saw at Allevue were horrible for the most part because these are people who did not get medical care early. This turned out to be a 31-year-old African-American male who turned out to have T10, T12 vertebral cocci. Miliary pattern on his chest x-ray, left upper lobe bullae, and he had positive cultures from a spinal abscess, and the CF was very high. I think it was like around 1 to 64. He was treated actually with both therapies, IV ampho and PO fluconazole. And as I mentioned, a lot of the experts and most people are doing this in people with really severe disease. There's not antagonistic problem, although there's a theoretical concern. MRI just showed persistent involvement. He actually required surgical debridement. And I've seen a case over at Cedars where a 31-year-old woman who was around 31 weeks pregnant, who actually had disseminated coccidioidomycosis and lesions all over her bones, including a large one on her hip that actually had to be surgically debrided. In these patients, you have to debride them because you're not going to be able to cure it with antibiotics or antifungals alone. So another case that I've come across is a man in his 20s presented with a 3-day history of fever, memory loss, severe headaches, allergies. He's got diabetes, hypertension, chronic headache, and he's also on end-stage renal disease dialysis. The cerebral MRA showed diffuse bilateral vasculitis and infarctions, and the cocci-CF and the CF and serum were positive. This is the most lethal form of coccidioidomycosis. This is coccidioidomycosis meningitis. Now, although that it's not a common disease, once a patient presents with this, it's incredibly difficult to treat. It's the most lethal form of infection. There's approximately 200 patients a year in the U.S., and it's a chronic granulomatous meningitis, usually basal meningitis. It can be associated with vasculitis, with infarcts. In fact, what this patient had. The treatments really are based on case studies we have from recent years, around the 1990s. 1993, Galgiani looked at fluconazole therapy for coccidioid meningitis, and he found that oral fluconazole was preferred. If they did fail, they would go to intrathecal ampho. Basically, they had a group of patients who had no previous therapy. They decided to start with fluconazole, and approximately 16 of 23 responded. People who had relapsed from previous therapies, meaning they had gotten IV amphotericin, perhaps even intrathecal amphotericin, had actually responded, 21 to 24, 37 out of the total, around 79%. There still was a fairly high non-responder rate, which approximately 21% of the total. Now, what's interesting here is that they used low doses of fluconazole. Most people would not use 400 milligrams. You could pump it up to 800, up to 1,000. Some people give them 1,200 milligrams if they can tolerate it. There's really very low toxicity if they don't have nausea and vomiting. There is some concern for hepatitis associated with it, but it's rare. And it's a drug that can be taken orally, so they can have a good lifestyle. Most of the time, though, if these patients are improving on fluconazole therapy, the minute they come off it, they recrudesce. It recurs. Itraconazole, the other azole who was our friend, was also studied. And it was noted that itraconazole patients, or patients who received itraconazole in 1990, a small study of chronic coccidial meningitis, patients who had received fluconazole or actually had received IV amphotericin or intrathecal ampho, 4 out of the 5 who had received intrathecal ampho, 4 out of 5 who had not received amphotericin actually responded, and 1 did not. And 1 of the patients, or 3 of the patients rather, who had actually received intrathecal ampho concurrently with itraconazole were able to come off it. And that's important because intrathecal amphotericin, which was once considered to be the standard of care for coccidial meningitis, meaning that physicians were desperate. There was really no treatment for these patients. As you noted in the history, these patients progressed and died ultimately. That was cutaneous, but some of the patients who did have coccidial meningitis would have a horrible death. Intrathecal amphotericin is basically putting amphotericin into the spinal fluid, and you get horrible consequences: arachnoiditis, severe nerve impairments. Most of these will resolve, but sometimes people have actual neurological impairments that do not fully resolve. It's a very difficult treatment to get, And there are patients who have received it who have actually had neurological impairments that remain permanent. My professor over at Allevue, Dr. Matheson, had actually tried to give somebody cisternal amphotericin, and they had basically lost all sensation in their upper extremities and were beginning to have difficulty breathing. They actually got better, but he said that he was never going to give it again after that. So this is important because the difference for these patients is dramatic. I mean, going from getting intrathecal amphotericin, being hospitalized, the risk of severe neurological impairment, compared to taking an oral drug, itraconazole or fluconazole, is tremendous. So we've really come a long way. Now, what's interesting is that even if you get better with fluconazole or itraconazole, you may still develop hydrocephalus initially with effective therapy. If you do, you need to be shunted. At this point, I would like to take some questions about coccidioidomycosis. In the general population, it's actually quite low. If you look at most people, there's about 150,000 infections a year. Most are asymptomatic, up to 2/3. So 5 to 10% will go on to have pulmonary cavities, and approximately 1% total of the people infected will go on to have disseminated forms of infection. Very difficult to treat.
When you're treating with the 800 or 1,200 milligrams a day, do you give it all at once, or do you spread it out like BID or TID?
It depends what they can tolerate. Most of the times I would give them 400 milligrams PO-BID. The interest as to whether the drug is fungostatic or fungicidal depends on the concentration. And what's interesting is the concentration of the drug in the serum and whether or not it's fungicidal doesn't seem to correlate clinically with improvement. If you can achieve a high enough concentration, most of the time the azoles will be fungicidal. If you look at the patients, though, at high concentrations and the serum's measured, they come off it, they recur, which basically means you can't penetrate all tissues well enough, so it's fungostatic in those tissues. So most of the time what I would do is I would give somebody fluconazole or itraconazole multiple times a day, because giving it once a day actually is more difficult to tolerate. Itraconazole actually is probably given better twice a day especially.
And does it ever make sense to change among the azoles, or should you
You could do
use
it.
the one?
Yes. I would start off with fluconazole. If they don't improve, you could try to use itraconazole. One thing you would consider is itraconazole, as I mentioned in the study, may be better for skeletal lesions. It may be better actually overall, but the issue with itraconazole is that patients may be taking other drugs that would interfere with its absorption. H2 blockers, PPIs. You really want to advise them to use a highly acidic cola before actually using it. So there's a few lifestyle issues that makes fluconazole a little bit more attractive. Yep.
How expensive is this stuff?
Well, fluconazole is actually
39 months.
It used to be incredibly expensive, up to $40,000 a year for some of these patients. Today, fluconazole has actually become generic, so it's quite a big difference. I don't remember the exact price of 30 tablets of fluconazole.
I missed what you said when you had that patient who is pregnant. What was your treatment there?
So she actually was pregnant, so she couldn't be treated with azoles. Azoles are actually teratogenic. That's one of the issues with it. So she actually was treated with IV amphotericin. One of the problems in her case was the fact that she actually had lesions, skeletal lesions. Without debridement, they're not going to resolve and would be a continued nidus for infection.
Do you see central problems with amphotericin, intrathecal amphotericin? Does it cross the blood-brain barrier?
Yeah, it's definitely an issue. People describe sensations of dizziness. People have problems with actual concentration, obviously. There's issues also with people having some cranial nerve impairments. It's an issue overall.
So it's just with the intrathecal treatment that they see that?
The IV amphotericin doesn't seem to be an issue, but what's interesting is that it doesn't seem to have those side effects, but people do use IV amphotericin to treat coccidioidomycosis meningitis because nobody wants to give intrathecal amphotericin, and it seems to work in some patients. So that's actually a fascinating aspect of the therapy.
What precautions can we take to avoid this disease?
So what I tell people is if you drive through the desert, put your car on non-recirc. And that sounds funny, but it's true. I wouldn't take a chance with it, especially if you're one of the higher risk factor groups. And also what we're trying to study in this disease is how we should try to protect people who are in industries that are exposed. For instance, one of that case I presented, the 31-year-old African-American male, was actually somebody who worked for the telephone company. If we can actually look at the areas of endemicity and make a clear-cut conclusion that these people are going to be at a higher risk, which they haven't been able to clearly do, they're going to basically be able to tell these patients not to work in those environments. That's another way they can actually try to prevent this. The other thing they're looking into is a coccidioidomycosis vaccination. There's some preliminary studies that actually look promising.
Wait, so then again, put your car on non-research?
Yes. If you're driving through the desert, for instance, and there's people who have gotten the disease this easily, or if you're actually doing archaeological digs, anything that you're going to be doing to inhale the arthroconidia could be an exposing risk factor. So you drive through the desert, you don't want air flowing in from the desert, you're passing by a dusty road, you basically inhale arthroconidia. The truth... Well, okay, maybe I didn't describe it correctly. What I meant is don't have the air circulating with the outside. Just keep the cabin closed. And what I was going to point out is that there are cases of people actually just spending limited time in places like Palm Springs and then going back to the East Coast and turning out to have coccidioidomycosis. Yes?
In the Kern County, the San Joaquin Valley area, when do they start considering serological tests where somebody comes in with severe URI, severe flu, quote, flu-like? When do they start, and what is the screening cost, roughly speaking?
The screening itself, I don't know the exact cost, but if somebody comes in with a severe URI symptom, endemic area, perhaps they've gotten antibiotics, they're not getting better, you could make the argument, well, why don't we just watch them? We don't even need to treat them. At the same time, you would want to know if they're not getting better a couple weeks later, what's going on. So that would be the juncture, I guess, where I would get the serological studies. I would go ahead, after 2 to 3 weeks, persistent URI symptoms not resolving, go ahead and get the chest x-ray and consider getting cocciserologies. I order cocciserologies quite often. I know people find it weird, but I saw so much of it during my fellowship. It's amazing. Here, probably a little bit less so, but up at all of you, you see people from the Antelope Valley. It's incredibly common.
When do you do a lumbar puncture before starting treatment? When do you worry about CNS? When can you start treatment without an LP? And the other one, you probably mentioned it, but what is the difference between the quantitative and the qualitative serology and the immunodiffusion and those things?
So basically what you want to do is anybody who has a CF titer greater than 1 to 16 is a concern for disseminated disease. So those patients, most authorities would recommend getting an LP. And what you'd want to observe at that point prior to starting therapy is the glucose, protein, cell count. You'd expect to see those improve with IV amphotericin. Most people don't give intrathecal ampho, but you'd expect to see those improve on a repeat LP several weeks later, probably a month later. The tests themselves, basically, as I mentioned, the serological tests, you have Cocci, IgG, and IgM tests. The IgG initially was a true precipitin where you basically had a coccidioidal antigen that would be bound by antibody, and they would form a tube at the bottom of a test tube. So you take the patient's serum, you'd basically expose it to coccidioides, one of the spherules, and you'd actually see a tube precipitin at the bottom of the tube. Now what they do is they take antibodies and antigen via ELISA, and they actually look to see if it's IgG positive.
Where are you with the, you mentioned that the skin test is no longer available. I'm kind of disappointed about that. I had used it in the past. And
the skin test is not available for the most part because most patients in these areas will probably have already been exposed, and the serological tests are actually just as good, much better. And there's not really anybody who's got the interest in making it. There are some uses for epidemiological studies, but...
Okay, thank you.